This is the presentation of Blockroom Protocols from Aravind Eye Hospital, Theni. Objectives of this presentation is to understand the role of MLOPs, role of doctors, eye cleaning before and after block, preparation of local anesthetic injection, uses of local anesthetic drugs, details in Blockroom checklist, selection of patients for topical subtenon anesthesia, peribulbar, retrobulbar anesthesia, procedure for topical subtenons, facial, peribulbar and retrobulbar anesthesia, procedure for administering test dose, triaging of patients in Blockroom, grouping of cataract patients in Blockroom. Role of MLOPs. MLOPs have to arrive at 6:30 am. They have to wash the legs and wear the OT gown, cap, mask and slipper. Cap should completely cover the hair, mask should completely cover the nose. Hands should be washed with Dettol liquid hand wash solution. Clean the block room. Collect sterile bin from CSSD after signing in the register. Check if the bin hole is closed. Check the autoclave indicator and stick the same in autoclave register. Write the batch number of injection and eye drops. Get the signature from blockroom doctor, OT and CSSD in charge. Complete blockroom medicine checklist, quantity and expiry date to be included. This is a picture of the blockroom medicine checklist. Role of MLOPs. To receive the patient from ward, give hand rub to the patient and help them to wear cap and mask. Help them to wear the coat. Check BP, pulse rate and saturation of oxygen. Role of doctors. To come to the block room at 7 am and sign in the check-in register. To segregate patients for block or topical and start preparing them. Daily make a hand list of complicated cases and ensure all the materials are ready. Examples: the availability of toric lens or multifocal lens, extreme IOL power availability and checking for viscoat and other things. Case-sheet checking and documentation. Demographic data has to be checked with patient orally, avoid yes or no answers and has to be cross-checked with wristband and case-sheet. Verify ocular stickers, A-scan, culture reports and pre-op instructions. Check if physician fitness has been obtained in required cases and if blood pressure and blood sugar is under control. Documentation with name, date and time. The special procedures done in the block room should be written in the case sheet with time and has to be entered in the EMR as well. Xylocaine test dose, IM sedation, checking BP or any procedure done other than the routine has also to be documented. Documentation of other events. Falls, repeat blocks, block related complications, systemic complications happened in the block room and OT, any adverse or sentinel event happened, if more investigations are sought or any postponed surgery, all have to be documented in detail in EMR and case sheet. Block room checklist. Wristband has to be checked for patient's name and MR number. Correct eye and sticker or marking has to be verified. Verify if all necessary investigations like vision, IOP, duct, blood pressure, blood sugar have been done. Physician fitness, if required, has been obtained. Check for pupillary dilatation. To confirm verbally if the patient has taken pre-op antibiotic. History of known allergy, if any, has to be elicited. Check for the advised procedure. It's phaco or SICS. Check for the type of lens and its availability. Patient should be blocked only if IOL is available, especially in case of extreme IOL power less than 19 diopter or more than 25 diopter, toric IOL, multifocal IOL. A-scan has to be verified for axial length, K1, K2 reading, IOL power, billing sheet has to be checked. Check counseling card and check consent form, GVP form. Any specific preoperative requirement like mannitol, oral glycerol, oral antibiotic, use of inhaler or nebulizer has to be verified. Examine the eye for redness, discharge, pustule, lid mass or meibomian gland dysfunction. If the patient has opted for toric IOL, toric marking has to be made by the doctor and same has to be documented in the pre-op checklist. Complete the pre-op checklist and sign. These pictures depict verifying the wristband for patient name and MR number, investigations, correct eye and sticker marking, A-scan, billing sheet, whether it is payment or insurance, checking for counseling card and checking the consent form and GVP form. This is a picture of pre-operative checklist. Indications for physician opinion. Patients with uncontrolled diabetes, hypertension, cardiac, stroke or epilepsy, asthmatic, patients with renal failure, dialysis or renal transplant patients, patients with liver diseases, seropositive patients, foot ulcer patients, patients with psychiatric condition, patients who require IV sedation and IV mannitol, and patients who are more than 70 years of age, other country patients, all will require a physician opinion for the cataract surgery. Indications for specialty clinic opinion. Patients who have less than 40 diopter or more than 48 diopter K value will require cornea clinic opinion. Unilateral high myopia or hyperopia will require IOL clinic for amblyopia. Significant astigmatism will require IOL clinic opinion for toric lens. Significant unilateral high astigmatism will require IOL clinic, cornea clinic opinion for corneal pathology or amblyopia. Post-LASIK, PRK or RK patients will require IOL clinic opinion for IOL power. Combined retina and cataract surgery patients will require IOL clinic opinion for IOL power. If axial length is less than 21 mm, IOL clinic opinion is for short axial length. Axial length is less than 20 mm, glaucoma clinic opinion is got for nanophthalmus. More than 25 mm of axial length requires retina clinic and IOL clinic opinion for periphery evaluation. Preparation of local anesthetic injection mixing Hyalase. Hyaluronidase is stored in ice pack between 2 to 8 degrees Celsius. One vial of Hyalase has 1500 international units. The bottle cork is cleaned with sterile wiper. Withdraw 2 ml from a 30 ml 2% xylocaine without adrenaline into a 5 cc syringe and inject into the Hyalase vial. Mix the drug by placing the vial between the palm of 2 hands and gently roll it. Withdraw 2 ml of dissolved Hyalase into the 5 cc syringe. Inject 0.5 ml each in 4 xylocaine injection bottles and mix the bottles by rolling between the palm of 2 hands. Label the bottle with opening date and Hyalase mixing date. Concentration of Hyalase should be 25 international units per ml of lignocaine injection. Uses of local anesthetic drugs. Injection 2% xylocaine with adrenaline can be given to all patients except those contraindicated. Injection 2% xylocaine without adrenaline can be given to patients with hypertension, cardiac illness, asthma, renal failure or dialysis, and stroke patients. Bupivacaine can be given to procedures with long duration and patients with xylocaine allergy. Selection of patients for topical or subtenonous anesthesia. Topical anesthesia is preferred in phacoemulsification in well-dilated pupil, uncomplicated immature cataracts, and cooperative patients. Subtenonous anesthesia is preferred in small pupil, weak zonules, corneal scar, combined surgeries, long duration of surgery, and uncooperative patients, children, patients with hard of hearing, and psychiatric patients. Indications for topical or local anesthesia in specialty procedures. Topical anesthesia is preferred for pterygium with autograft, minor procedures which includes AC paracentesis, foreign body removal, intravitreal injection, C3R, and resurgeries, example IOL redialing and AC wash. Subtenon anesthesia is preferred for SICS, ECCE, trabeculectomy, vitreoretinal surgeries, squint surgeries, optic nerve sheath fenestration, resurgeries like anterior vitrectomy, and wound suturing. Peribulbar or retrobulbar anesthesia is preferred for repair of open globe injury, cataract surgery, post-RD or post-scleral buckle, and some cases of therapeutic penetrating keratoplasty and trabeculectomy. Eye cleaning before and after block. Explain the procedure to the patient. Apply hand rub. With the patient's head tilted up and using pouch method, apply 1 drop of 0.5% proparacaine eye drop. After 10 minutes, apply 1 drop of 5% povidone iodine eye drop. And clean the eye with 10% iodine solution using dry cotton held with sterile forceps. Clean from medial to lateral side with one sterile dry cotton soaked in 10% solution for lower lid and another one for the upper lid. Procedure for topical anesthesia. Consumables required are 0.5% proparacaine eye drops, 5% povidone iodine eye drops, 10% iodine solution, hand rub, torchlight, sterile artery clamp, dry cotton and wiper, and yellow bag. Procedure for topical anesthesia. Select the right patient for topical anesthesia. Explain the procedure to the patient and get patient's cooperation. Apply hand rub. Check the dropper bottle for any damage or color changes and expiry date. Place the patient in a comfortable position. Eye cleaning procedure is done. Administer 1 drop of 0.5% proparacaine eye drop twice with 5-minute interval. After 10 minutes, apply 1 drop of 5% povidone iodine eye drop and clean the eye with 10% iodine solution using dry cotton held with sterile forceps. On the operating table inside OT, 1 drop 0.5% proparacaine eye drop is instilled after applying speculum. Procedure for subtenon's anesthesia. Consumables required are 0.5% proparacaine eye drops, 5% povidone iodine eye drops, 10% iodine solution, injection 2% xylocaine mixed with hyaluronidase, hand rub, headband light, sterile artery clamp, dry cotton and wiper, yellow bag, sterile bin and perforated box, 5 cc syringe, universal wire speculum, Hoskins plain forceps, Westcott spring scissors, and 19 gauge blend cannula. Procedure for subtenon's anesthesia. Select the right patient for subtenon's anesthesia. Case sheet to be verified and explain the procedure to the patient. Apply hand rub. Apply 0.5% proparacaine eye drop. Take subtenon set from the bin and withdraw 3 ml of local anesthetic drug. Insert cannula. Apply 0.5% proparacaine eye drop. Apply iodine eye drop. Eye cleaning is done. Apply wire speculum. Apply 1 drop of 0.5% proparacaine eye drop and 1 drop of 5% povidone iodine eye drop. Conjunctiva and Tenon's capsule are picked up 7 to 10 mm from limbus using forceps in the inferonasal quadrant between the medial rectus and inferior rectus muscle. A small cut is given using scissors and subtenon space is assessed. The cannula is inserted into the opening made and advanced posteriorly along the contour of the globe, and injection is given into posterior subtenon space at the speed of 1 ml per 3 seconds. Cannula is gently withdrawn respecting the curvature of the globe. Eye speculum is removed. Gentle pressure is applied using sterile cotton. Eye cleaning is again done. Pad and bandage applied. The used subtenon set is kept separately. And the details of the subtenon anesthesia has to be entered in the EMR as well. Make sure the eye is completely closed, pose block to avoid cornea from drying up. If the eye is completely open or half open, facial block can be given or eye can be patched with sterile cotton wiper and micropore tape until the patient is made to lie on the operating table inside the OT. Check for extraocular movement after 3 minutes. In case of nasal pterygium, identify the inferior edge of the pterygium and use the forceps to push the pterygium to one side. This will allow access to normal conjunctiva. Complications are subconjunctival hemorrhage and chemosis. Procedure for retrobulbar anesthesia. Sterile tray and 5 cc syringe, 22 gauge 1.5-inch long needle, injection 2% xylocaine mixed with hyaluronidase, 5% povidone iodine eye drops, 10% iodine solution, hand rub, torchlight, sterile artery clamp, dry cotton and wiper, yellow bag, and saline soaked pad and pinky ball. Procedure for retrobulbar anesthesia. Apply hand rub, eye is cleaned, explain the procedure to the patient. 3 ml of local anesthetic solution is withdrawn into 5 cc syringe and cannula is inserted. Air bubbles in syringe are pushed out. With the patient in supine position, ask the patient to look straight ahead. Prick the skin with bevel facing up at the junction of outer 1/3 and inner 2/3 of lower lid just above the inferior orbital rim and advance the needle posteriorly and downwards towards the orbital flow. Then the direction is directed posteriorly and parallel to the flow and finally directed posteriorly and upwards. Withdraw the plunger of the syringe to check that the needle has not punctured any blood vessel. Inject the anesthetic solution slowly and appreciate ptosis and proptosis and gently withdraw the needle. Apply massage with wiper to avoid intraoperative positive pressure. Eye cleaning is done. Make sure the eye is completely closed post block to avoid cornea from drying up. If the eye is completely open or half open, facial block can be given or eye can be patched with sterile cotton wiper and micropore tape until the patient is made to lie on the operating table inside the OT. Check for extraocular movement after 5 minutes. Complications include retrobulbar hemorrhage, globe or nerve perforation, extraocular muscle injury, brainstem anesthesia, or death. Procedure for peribulbar anesthesia. Consumables include sterile tray, 5 cc syringe, 23 gauge needle, injection 2% xylocaine mixed with hyaluronidase, 5% povidone iodine eye drops, 10% iodine solution, hand rub, torchlight, sterile artery clamp, dry cotton and wiper, yellow bag, saline soaked pad, and pinky ball. Apply hand rub, eye is cleaned, explain the procedure to the patient. 5 ml of local anesthetic solution is withdrawn into 5 cc syringe and cannula is inserted. Air bubbles in syringe are pushed out. With the patient in supine position, ask the patient to look straight ahead. Prick the skin with the bevel facing up below the lower lid at the junction of outer 1/3 and inner 2/3 and advance the needle posteriorly parallel to the orbital floor outside the muscle cone. Withdraw the plunger of the syringe to check that the needle hasn't punctured any blood vessel. Inject 1.5 ml of anesthetic solution slowly. Gently withdraw the needle. 1.5 ml is injected above the upper lid between the superior orbital margin at the junction of medial 1/3 and lateral 2/3 in the same space with the bevel of the needle facing down. Apply massage with wiper to avoid intraoperative positive pressure. Eye cleaning is done. Make sure the eye is completely closed post block to avoid cornea from drying up. If the eye is completely open or half open, facial block can be given or eye can be patched with sterile cotton wiper and micropore tape until the patient is made to lie on the operating table inside the OT. Check for extraocular movement after 5 minutes. Complications include retrobulbar hemorrhage, globe or nerve perforation, extraocular muscle injury, brainstem anesthesia, or death. Procedure for facial anesthesia. Consumables include sterile tray with 5 cc syringe and 23 gauge needle, injection 2% xylocaine, hand rub, sterile cotton wiper, yellow bag, and puncture-proof container. Procedure includes apply hand rub, draw 2 ml of 2% xylocaine, a sterile 5 ml syringe, and attach 23 gauge needle. Discard the air bubbles. Ask the patient to open and close their mouth and feel for the temporomandibular joint. Clean the area using hand rub solution applied on a sterile cotton wiper and discard it in the yellow bag. Inject anesthetic solution slowly just below the head of the mandible at its neck where the facial nerve winds around. It's called O'Brien's technique. After injection, apply gentle pressure on the site of the injection with a sterile cotton wiper. Discard the needle into puncture-proof container and wiper into yellow bag. Procedure for administering test dose. Consumables include 1 cc syringe and 26 gauge needle, injection 2% xylocaine, hand rub, sterile cotton wiper, marker pen, yellow bag, puncture-proof container, and crash cart in case of emergency. Procedure for administering test dose. Wash hands and wear gloves. Apply hand rub. Verify the case sheet and explain the procedure to the patient. Clean the site on the forearm with wiper soaked in hand rub. Draw 0.1 ml of injection xylocaine 2% in a sterile 1 cc syringe. Discard air bubble. Inject the drug intradermally with a 26 gauge needle. Apply gentle pressure on the site of injection with a sterile cotton wiper. Discard the needle into puncture-proof container. Make a mark around the injected area. And the details of the test dose has to be documented in the case sheet. Triaging of patients in block room. Avoid long waiting time within OT for patients with diabetes, cardiac illness, asthma, hypertension, patients with renal failure, dialysis, renal transplant, stroke or epilepsy patients, and patients who are aged above 70 years, and patients who are supported with wheelchair. Patients to be posted last in operation theatre are patients with foot ulcer, active Hansen's disease or leprosy, active tuberculosis, hepatitis B or C infected patients, and seropositive patients. Grouping of cataract. Cataract is grouped into 4 classes based on clinical condition. Group 1 includes immature cataracts, dilated pupil, and mature cataracts opted for SICS. Group 2 includes hard cataract, mature cataracts opted for phaco, hypermature cataracts, posterior polar cataract, complicated cataracts, traumatic cataract, and IOL power which is less than 10, axial length less than 20 mm, cataracts with small pupil, pseudoexfoliation. Group 3 includes IFIOL, SFIOL, and CTR. Group 4 includes all premium IOLs like toric and multifocal IOLs, femtosecond assisted surgeries. These protocols are to relieve the anxiety of the patient, to take care to avoid surgical related infections, and to ensure quality in every aspect of eye care delivered with utmost safety to the patient. Thank you.